Hi guys, how are you all? I am Dr. Ramakrishna Chaitanya, Anesthesia faculty for the Marrow. Hope you guys are doing good in your preparation and all these things. It has already been 6 months in this academic year. That means we have completed our half of our journey in preparation for the NEET examination. In these 6 months, so many things have happened in our lives. The first and most important thing that has happened is the effect of COVID, which has changed. So many students are working in intensive care units. Some students are stressed out. Some students are feeling depressed that they are sitting in the home, not working at this period. So many things have been running down through this. Along with this, in the recent weeks, there are two things that have happened. The conduction of the central examinations, AIIMS, PGI and JIPMER examination. Most of you have attempted this examination. Some came out with flying colors. You might have seen their interviews, or you might have asked them their preparation strategies, everything in the recent past. And the second thing is, some students have not cleared. Some students are feeling slightly depressed. What would happen? We are not on the way. So what I will do in this particular session is, I will initially discuss the recent MCQs that have been asked in the section of anesthesia and critical care from the central examinations. Okay, in the second part of the session, I will not take much of your time, but I will try to add some of the points which might help you in your preparation strategies. Okay, so the first thing is, first we'll start with the academic discussion. So anesthesia and critical care MCQs that have been asked. The moment I say critical care MCQs, most of the students, they get panicked, really panicked. Sir, you have not taught us critical care medicine. How are you expecting me to write these MCQs? Now I would like to clarify one thing for you. Critical care medicine, don't think it is a special entity or a separate entity where one faculty comes, sits and tries to teach you critical care medicine. Critical care medicine is never taught like this. That is for sure. Then how to answer this question? We have a very good faculty in medicine who has been teaching lot of things in medicine. That itself is sufficient to answer these critical care MCQs. Only thing you need to have is, you need to have that clinical acumen to answer these kind of questions. Okay, it's not like, it's not rocket science which we don't know or which we can't apply. It's a simple thing. And in these examination or coming in the NEET examination also, I'm very sure that they will not ask you about the complicated ECMOs or complicated what to do this dialysis and all these things. So it would be a simple thing. Provided you know your medicine thoroughly, you can answer most of your critical care medicine, because in your MCI there is no perfect curriculum that have been defined for critical care medicine. Okay, so don't worry about critical care medicine. Whatever you are reading in your medicine part, please think that what will happen if the patient condition gets worsened and if he gets admitted into an ICU. There are many things which can worsen the situation, like metabolic encephalopathy, encephalitis, malaria, what not, diabetic ketoacidosis. Whatever you read it in medicine, the same thing you need to apply in critical care medicine. So I particularly feel that you should be able to confidently approach that critical care medicine rather than get tensed off with this word critical care medicine. So with this small introduction, let us start our discussion. So the first question that has been asked in the AIIMS examination: what is the reason for giving thiopentone sodium and succinylcholine during ECT? What is ECT? ECT is a electroconvulsive therapy. So what are the options that have been given? The first option is to provide anesthesia and muscle relaxation. The second thing is to reduce secretion. The third thing is to bring the calming down effect. The fourth thing is to maintain the memory and acting as mood stabilizer. Okay, now we all know why do we use ECT? We use ECT to treat in the treatment of severe depression. Now, what are the anesthetic considerations when you are giving the ECT or modified ECT, whatever it is called? Why it is called modified? Previously, long back in 1950s or 60s, I am not very sure, people used to apply the current shock. Why they used to apply the current shock without giving anesthesia to the patients? This is called as unmodified ECT. Nowadays, it has become very common practice that we need to give anesthesia for delivering of this ECT. Now, what is the thing that is happening what happens in ECT? Why we need to give anesthesia? The answer is very simple, because in ECT, we are going to apply current on your scalp so that it leads to generalized seizures. So what will happen if there is, what is the problem with the seizure? if there is a generalized seizure, the patient is struggling violently, so sometimes these can induce serious musculoskeletal damages. Now, if it can lead to serious musculoskeletal injuries, what I need to do is, I need to also consider what are the physiological effects of inducing seizures in a patient. So what will happen if I induce seizures in these patients is, initially there will be a small duration of 30 seconds around, you will have a parasympathetic response followed by an extensive sympathetic response. Right? So what I can do, how my anesthesia can help you. So the options are pretty straightforward in these MCQs to provide anesthesia. Why I need to provide anesthesia? Because I need to relax all his muscles like this. Otherwise, if his muscles are very tight, it can lead to serious muscular injuries, bone fractures, etc. And second thing is, I need to provide a stable environment so that he can be able to tackle this elevated sympathetic response. Right? And it's a very painful stimulus. You are going to apply seizures on a patient. So how my anesthesia can help you? So the first thing is, what are the drugs that are present on my Boyle's machine? A very important drug is amnesia. How can I provide amnesia? So there are midazolam. There is in the pre-medication we can add midazolam to these patients. This produces a sedative calming effect. But adding alone midazolam, will it help me? No, it will not help me, because I need to give proper anesthesia for the patient. So if I need to give proper anesthesia for the patient, why I need to give proper anesthesia is, suppose if I give you alone muscle relaxant to you, you will be aware that one by one, all of your muscles will be getting paralyzed. When your muscles are getting paralyzed, imagine starting from the fingers, everything is getting paralyzed. What will happen? You feel it is one of the most painful stimulus that a patient can experience. Okay, so I need to sedate him. I need to put him to amnesia. So for that amnesia, he should not recollect whatever that has happened in this period. So what I will do is, in the pre-medication, I would add small amount of midazolam. The second thing is, I would also like to add small amount of atropine. Why atropine? Because application of seizures, it can also produce some amount of salivation, lacrimation, because these patients are mostly depressed. They will not be able to take care of themselves. So in order to reduce these, I will add atropine or glycopyrrolate. The third thing is, I'll give him a proper anesthesia. So the proper anesthesia is by administering induction agents. What is the induction? Till now in your examination, they have asked, many times this question has been asked, what is the induction agent of choice in patients coming for ECT? The answer is methotrexate. Sir, you said methotrexate and suddenly you are asking about thiopentone sodium. Why I am saying like this is, the answer is very simple, because methotrexate is not available in the market. Most commonly in our practice, see this word practice. Many of these examinations, they are not going by standard literature. They are telling what they are doing. Right? So in our practice, we give either thiopentone sodium or propofol, because methotrexate is not available. So if someone asks you what is the drug of choice, if for ECT, you put it as methotrexate. But in practical purposes, I said theory is different, practical part is different. So in all practical purpose, either we use thiopentone sodium or propofol. So in this question, he has been asked about thiopentone has been given. So the reason for giving thiopentone is to induce anesthesia so that he gets sedated nicely. He will not recollect what is happening there. Right. The second thing is muscle relaxation. I said your muscles are contracting vigorously. So your muscles should not contract. So application of current, it leads to generalized seizures. I should not get all the muscles should be contracted like this. So I need to give him muscle relaxation. So what muscle relaxation? Because you all know ECT is a very, very small duration procedure. ECT is a very small duration procedure. It will take around hardly 1 to 2 minutes of time. So which muscle relaxant I can give to the patient? The answer is very simple, that is succinylcholine. Sir, now you might get one doubt in your mind that, sir, you said this is a very small procedure that can be done on the patients. Why don't I give propofol? Yes, you can give propofol. That's not a contraindication. Why don't I use any other drug like atracurium or rocuronium? Because succinylcholine is one drug which will the effect will be terminated within 10 minutes. The procedure will be done in 1 to 2 minutes. So obviously we prefer to use succinylcholine in this provision of muscle relaxation. Nothing more than that. It's a very small daycare procedure. I want my patient to get out quickly. In this question, he particularly asked thiopentone sodium and succinylcholine. But if someone asks you, right, what is the drug of choice, please choose. If the methotrexate is given, please choose methotrexate. The rest of the thing is we apply all the monitors and we will deliver the current to the patient. We will deliver the current to the patient. Okay, so that we are inducing seizures in a controlled environment. So this will help in recovery of the patient. So the options are also pretty much clear in this session, that giving thiopentone sodium and succinylcholine is to provide anesthesia and to reduce and to induce muscle relaxation, right? To induce muscle relaxation, right? So let us see the rest of the options. The rest of the options are to reduce secretions. Okay, we all know thiopentone sodium, there is no effect. To bring calming effect, fine. To bring calming effect is not only one thing which I require. I said you muscle relaxation is also required, right? So the options are to maintain memory, mood stabilizer, all fancy options are there. So just leave it. The question is straightforward question which has been asked in AIIMS examination. So the only thing what you have to learn is most of the MCQs, they are practical oriented approach. Believe me, this is going to happen in your NEET examination also. Okay, let us move to the second MCQ, a very slightly different MCQ in the second. That is, what is the second MCQ that has been asked in recent AIIMS examination? Right. What is the mechanism behind transcutaneous electrical nerve stimulation used in pain management? Slightly tricky question, but it's not very tricky also. The options, if you look out, the options are very clear. You can easily answer this kind of MCQs. Okay, so I'll tell you in the end session how to answer this kind of MCQs. But you know, what is this transcutaneous electrical nerve stimulation? Most of you might have not seen it, or those who have seen, went to the physiotherapy department also, they might have seen this TENS. TENS is used in the management of, this is the TENS machine which I wanted to show to you. So where what they do is they apply electrodes on the skin and they will deliver the current. So what is TENS? TENS is a transcutaneous electrical nerve stimulation where strong but non-painful electrical impulses are applied on the skin so as to produce analgesia. So remember, what is TENS? TENS is a transcutaneous electrical nerve stimulation. It is a application, strong but non-painful electrical impulses are applied on the skin so as to produce analgesia. There are various types of TENS that are available. That is a conventional type of TENS, acupuncture like type of TENS, and segmental TENS. Okay, so we'll not go into the details of TENS because it is not necessary for your part. So what is the mechanism behind it? The mechanism is very, very simple. That is called as gate control theory. You might have read it in your physiology part. That is, what is gate theory? That means when we activate large diameter fibers, I said you, when we are producing the current, when we are applying current on your skin, initially it will activate the large diameter fibers which competes with the small diameter fibers, so that the impulse projection from the small diameter fibers is reduced. So the patient will not feel that much amount of pain. So this TENS is basically used in the treatment of mostly for the chronic pain management, not only for the chronic pain management, but it can be also used for the treatment of acute pain management also. And also there are other modalities of electrical stimulation that is called as spinal cord stimulation, where we insert the electrodes in near your epidural region and we are going to directly stimulate the A beta fibers, or the deep brain stimulation where the electrodes are implanted in your brain, thalamus, periventricular area, periaqueductal areas of the brain, and where the impulses are produced. So we'll not go into the complete details of the TENS, but conventional TENS, if you look at the options also, the options are very clear. You can easily answer this kind of MCQs because the options, if you do repeated MCQs, this is the biggest advantage what you can do. You can rule out one option. Okay, out of all these four options, see very closely, one option is odd man out. Every time I tell, in the later session, I'll tell you how to rule out this. So you can see this, out of all these things, the one is very clear, that is gate control theory. This was like simplified in 1969 by Melzack and Gate, on his name only, Gate theory of hypothesis. He said, like when you are activating when you are activating the large diameter fibers, what it will do is it preferentially blocks the conduction of the small diameter fibers, and we all know in the small diameter fibers they carry the pain sensation. A delta and C fibers, they carry the pain sensation. So the answer is pretty much clear, that is the gate control theory. So what is this descending inhibition? So sometimes what will happen is in your spinal cord or in your brain there will be activation of inhibitory receptors also. This do happen in TENS, but in conventional TENS, the main mechanism of TENS is gate control theory. The main mechanism, desensitization, central inhibition, descending inhibition, these are all not really applied for the TENS. The only thing which is classically applied for conventional type of TENS is gate control theory. Okay, right. The third question which we are going to see, in an intubation patient kept on TPs, later develops breathlessness. An X-ray chest showed white out of right lung. What is the next step in management? The moment I see this kind of question, most of the students after this MCQ, they have asked me, sir, intubated patient, TPs, breathlessness, sir, this is a critical care medicine MCQ. We are worried about this critical care medicine MCQ. Now, don't get panicked when you look at these kind of MCQs, because look at the options. When you look at the options, the answers are very, very clear. The options you can easily rule out by looking at these options. This is the advantage of subjects like critical care medicine, because we are not going to ask you something which you don't know. It's a very simple thing. So look at the options. Start antibiotics and blood culture. You might have read about sepsis and all the management about the sepsis, where you will never start an antibiotic before taking the blood culture. So the option is very, very clear, that starting off antibiotics and blood culture. The second option, blood culture and then start antibiotics. Again, it doesn't look good, because the patient is having breathlessness. That means he has got some problem in his lungs. Okay, we'll leave that option. The third one is vigorous suction and physiotherapy. The fourth one is ultrasound guided aspiration. Okay, now if you look at, might be they, I don't know, because this is a recalled question, might be they might have given some X-ray like this, where there is whiteout of lung, complete whiteout. I have just kept the picture of whiteout of the lung. Now, whenever they say whiteout of the lung, you need to understand what are the reasons, common causes for whiteout of the lung. The commonest cause for the whiteout of the lung is collapse. The lung segment, if the area is, you might have read it in your radiology part, you might have read that if there is air, then only you can see the blackness on your chest X-ray, right? So when the lung is collapsed, that area will be, it is shown on X-ray as a whiteout region. So one of the commonest cause is collapse. The second commonest is consolidation. Even consolidation patches also, it might look as a whiteout region. Or sometimes pleural effusion. These are the most common. There are some other causes like, pulmonary agenesis, etc. But these are most common things: lung collapse, consolidation, and pleural effusion. Now you can easily identify like what happens in the collapse. What happens in the collapse is, in collapse, why there is collapse. Now you look at the question, go back to the question and see. In the question he has clearly mentioned that the patient is kept on TPs. The patient is kept on TPs. What do you mean by TPs? The TPs is something which we use to wean off. Once we remove off the ventilator, we keep it on TPs and 10 liters of oxygen is supplied to him. Like just before extubation, we keep the patient on TPs, so that we will see whether the patient, if I extubate the patient, whether he will be able to tolerate or not. This is what my whole goal is. Okay, so we will keep him on the TPs. That means he is about to be extubated. So we will not keep ventilator for a patient normally, right? So that means he has some problem. We don't know what is the problem, but he is about to extubate. That means he is about to extubate means that means the problem that he has in the lungs, have been treated well in that ICU. Okay, so if you look at the options, see here, look at the options. So that means the patient might have consolidation, the patient might have collapse, the patient might have pleural effusion. But if there is a consolidation patch, do you think I am going to extubate the patient? No, I am not going to extubate the patient, right? That means if there is lot of effusion, whiteout of the lung, if there is minimal effusion, I am okay with it. But if there is lot of effusion, do you think I am going to extubate? He will not be cooperative for extubation. So the TPs trial fails. So in this question, he has clearly asked you, in the patient is kept on TPs. That means he is about to be extubated. is about to be extubated. So there is no point in, like, start antibiotics, blood culture and antibiotics. Now there is complete whiteout of the lung. I said you one of the reason, most common cause is collapse of that lung. Why there is collapse of that lung that has happened in this patient? The answer is very clear, because the tube might be displaced, because he might be on ventilator for longer period, or the tube is blocked with the secretions. Even if the tube is blocked with the secretions, what will happen is, most of the times, the right side of the lung, there what will happen, it will be completely filled up with secretions. So if you have worked in ICU, you would know that every second hourly in an intubated patient, we do good chest physiotherapy. And we will try to suck out all the secretions. We'll send even the culture for the secretions also. So the answer is pretty much clear that this lung has been collapsed might be because of secretions. They might not have given that much amount of care, endotracheal tube care, in the patient in ICU. So that might be the most common reason. Ultrasound guided aspiration. Before extubation, I would never like to do any procedure on the patient. I not like to put anything into his lungs. So if you look at the options, think logically. If you have worked in an ICU, this answer, you can easily answer it, because the answers are not so confusing. Suppose if you had given some other options, there is a scope for confusion, which I feel, but it's a very clear-cut solution that the answer is vigorous suction and start chest physiotherapy, so that, the lungs will open up. The moment the lungs will open up, your chest x-ray, again it will show the black color, and you can easily extubate the patient. So the patient is kept on TPs and he developed breathlessness. That means one of the lung is collapsed. That is the reason why he developed breathlessness. Okay, so do good chest physiotherapy, do adequate suctioning, he will improve. Right? So pretty straightforward clinical oriented question. The next question, again this is critical care question which has been asked. Okay, a patient with blunt chest trauma has been started on mechanical ventilation. Which of the following is not correct about initial setting? See here, read the question properly. This is the problem, because if we don't read the question, what will happen is we are about to commit the mistake. In the previous question also I said, the patient is on TPs. TPs, whether you know or not, it is like about to be extubated. This is a question, which of the following is not correct about the initial setting? That means, in the initial phase of starting of mechanical ventilation, which of the following we will not set it? Again, students are really confused with this MCQ. They started asking me, sir, what is the correct answer here? So this is slightly tricky question, because, blunt chest trauma, there can be so many things that can happen in a patient with blunt chest trauma, starting from 1 or 2 rib fractures to multiple rib fractures. Again, it can lead to lung contusion, it can lead to disruption of the trachea, it can lead to injury to your mediastinal structures, it can lead to the injury to your heart, great vessels, whatnot. Okay, so he has very randomly or vaguely asked blunt chest trauma. So what is the mechanical ventilation? So those who have worked in ICU, and I have said in the beginning how to keep the settings. So inspiratory flow of 100 to 120 liters per minute. Okay, let us see. PEEP 0, tidal volume 10 ml per kg, FiO2 100%. Now the answer is slightly tricky, I do agree, because when I read this question initially, I was also slightly confused. Then later I saw this word, the catching word, initial setting. So when we are starting up a ventilator on a patient, what will happen is, first understand what is the pathology that has been happened to the patient because of blunt chest trauma. I said there can be many reasons. So all these reasons, suppose if there are 1 or 2 rib fractures, nothing you can do, you provide best analgesia to the patient, because once the ribs are fractured, patient cannot breathe properly, and this leads to collapse. Once there is collapse of that segment, it leaves a good source for the infection, and all the things will go into a downward spiral. Okay, so if the question is very specifically asked, 1 or 2 rib fractures, nothing you can do, provide analgesia. How to provide analgesia? There are various ways of providing analgesia, like, even I can give opioids, I can give paracetamol, I can give diclofenac. The best form of analgesia I can give to the patient is epidural analgesia. And believe me, this question, if you have done anesthesia modules, this question has been given in our module. right? In the QBank module, which is the best form of analgesia, they have asked anesthesia, but the same question. If you have 1 or 2 rib fractures, the best form of analgesia I can provide to you is epidural analgesia, not anesthesia, epidural analgesia. Once I remove the pain, you will start breathing normally. Suppose there are multiple rib fractures, 4, 5, 6, 7, 8 rib fractures, what I can do you? This can lead to a condition called as flail chest. Where there is a paradoxical movement. That means during inspiration, your chest wall is sucked in, and during expiration, it will move out. So this is a very serious condition. You need to stabilize the chest wall. Suppose if the patient is alert, active, you can start off non-invasive along with this chest binder. Suppose if the patient is having some sort of, most of the time this flail chest, they can have this condition called as a pneumothorax. Okay, so if there is a condition of pneumothorax, what will happen is you need to first and foremost, I have said in my videos many times, first and foremost tackle that pneumothorax by putting an ICD. Then only start a positive pressure ventilation. So this is the second thing. The third thing that can happen to a patient with chest trauma is lung contusion. So this lung contusion, what will it do is, this lung contusion, the affected lung, the capillaries, there will be damage to the capillaries, there will be alveolar seepage, there will be disruption of the capillary membranes leading to flooding of the alveoli, affecting the diffusion of oxygen. So this leads to a condition that is called as acute lung injury, and soon it can land up into ARDS like picture. So if you know this basic concept, if you go back to your basic medicine knowledge, what are the causes of ARDS? If you look at one corner, there will be slightly sitting there that in one corner they will be mentioning that lung contusion. Normally, if you are awake, moving around, there will not be chances of lung contusion. So unless you have a blunt chest trauma, there are chances of lung contusion which can lead to acute lung injury, and it can lead to ARDS like picture. Now, whenever there is lot of literature is there on ARDS, how to start the ventilatory strategy, the answer is very clear. The question what he has asked is initial setting. So in any patient, when I intubate the patient, the first thing I will do is initially I will keep FiO2 of 100%. Because I don't know the patient general condition. Initially, for a brief period, what I will do is I will keep FiO2 of 100%. So this is the right option. Okay, FiO2, I will keep it at 100%. But the moment I put the tube into the patient trachea and I see all the vital parameters are settling down, soon I will reduce the oxygen concentration to the least possible. I'll come down slowly from 100 to 90 to 80 to 70 to 60, and I will make sure I will deliver minimal amount of oxygen to the patient. Because we all know in ARDS, delivering high concentration of oxygen also leads or also aggravates the acute lung injury. So initial settings, I will start with 100% and slowly reduce. I will make sure I will not aim. If you look at the saturation in ARDS, I will never aim in ARDS to keep the saturation around 98, 99 and 100. I am very much happy if the saturation is maintained between 88 to 92 also. I am very much happy with the patient. So, but for that keeping 88 to 92, what I will do is, I will keep first initially 100 and I will slowly come down on the FiO2. So, initial setting of FiO2, still I can agree. Inspiratory flow, the first option, inspiratory flow of 100 to 120 liters per minute. Okay, normally ventilators, what will we do is, in the beginning of ventilators, most of the ventilators, we keep somewhere around, 60 to 80 liters of flow will be taken up by the ventilator. This is what we are not going to set. We are not going to set this because most of the ventilators, they commit on a inbuilt fashion. The moment you connect it to the oxygen source, it will take around 40 to 60, depending on the type of the ventilator. Some ventilators even take 60 to 80 liters of also, or some ventilators, older type of machines, they even take 100 liters per minute also. So I am not going to adjust the inspiratory flow rates also in the initial period. So let it be like that. The third one is PEEP. PEEP we all discussed in the ventilatory part module. What is PEEP? Positive end expiratory pressure. Initially 0. Sir, in ARDS, I have learnt it very strongly that application of PEEP will reduce the incidence, or it will help in recovery of the patient from ARDS. Yes, exactly. The answer is PEEP 0. Application of PEEP is essential. But suppose, imagine if there is a blunt chest injury. If there is a blunt chest injury, that means most of the times his head might also be involved. There can be chances of head injury also. There can be so many things that have happened. So what we do is, yes, definitely application of PEEP is important. But I said you, chest injury also affects. There can be chances that his heart might also be affected. Because of the chest trauma, his ventricular filling might be affected, or he might be having head injury which is not detected, so it can rise at ICP. Application of PEEP, it will cause hypotension. Because PEEP, what it will do is, it will try to positive end expiratory pressure. So, in the end of expiration, instead of collapsing of the alveoli, it is trying to make up the alveoli, and it is trying to keep that alveoli open, so that what will happen is, it might affect the ventricular filling. Right? The second thing is, sometimes PEEP application, it also increases my ICP. So what I will do in the initial period is, the moment I keep 100% oxygen to the patient, the moment I keep initially, I will see the PEEP 0. Okay, fine. If the saturation is maintaining, that is good for me, because I don't know what is the problem inside, and the question has been asked very vaguely here. So initially, PEEP keeping 0 is okay, but I will not stop at PEEP 0. I will not stop at PEEP 0, and I will try to escalate the PEEP. I said you, there are huge chances, there are high chances that the patient will have a saturation on the lower side, somewhere between 88, 92, or sometimes even 80 also. So in those conditions, what I will do is, I will try to keep maximum oxygen in the initial period, and I will try to reduce the FiO2. Initially, I will start with low PEEP and try to escalate the PEEP, so that he maintains. So it's not a hard and fast rule. If someone asks me PEEP of 0, looking at the other options, if someone asks me PEEP of 0, I will not agree to it, but it's not like, it's not uncommon. We start with 0 and slowly we escalate. 1, 2, 3, 4, 5, 6. We start slowly escalating. And our target at the end of this scenario, at the end of this picture, we need to see a nice decent value of 88 to 92 on saturation. The patient should not go into hypoxemia. So initially keeping PEEP 0 is slightly acceptable. I know this is slightly controversial, because I said, blunt chest trauma, he has not mentioned anything. Tidal volume of 10 ml per kg. Last option. Last but one option. Okay. Tidal volume of 10 ml per kg. You have read many times in your medicine part in ARDS. What we do is, we keep the patient low tidal volumes. Why low tidal volume? I don't want your alveoli to be stretching out, stretching in, stretching out, stretching in. Why? Because if I am going to increase the alveoli stretching out and stretching in, what will happen is, this might aggravate alveolar injury. This might aggravate alveolar injury, and it can aggravate acute lung injury. So I always start with a tidal volume of 4 to 6 ml per kg. So if I look at these 4 options, in the initial phase also, I will never opt of a 10 ml per kg tidal volume. Yes, PEEP is also a possibility. I don't know what was there in the question paper setter's mind at the time of setting, but with this vague kind of question, I probably think tidal volume of 10 ml per kg, because we don't never advocate high tidal volumes in any patient. The reasonably good tidal volume what we keep on the patient is 4 to 6 ml per kg. Okay, PEEP, I said we will start at 0 and we will escalate it. We will not stop there. 100% FiO2 and we will not stop there, because it will again injure. It will cause more injury. So in the initial settings also, I will not keep a tidal volume of 10 ml per kg. So what I probably feel in this MCQ, the answer is tidal volume of 10 ml per kg is not the right answer. This is not the correct initial setting. This is a slightly tricky question. I do accept it. But the rest of the 3 questions that have been asked in AIIMS examination are more or less, they are straightforward MCQs. I don't find any difficulty, or you should not feel any difficulty if you are preparing well. Okay, let us see the rest of the questions that have been asked in JIPMER and PGI. Some of the questions I have collected, I don't know, I might be missing on few of the things. These have been asked by the students. So I'm just discussing these questions. Okay. Fine. Fifth one. Which of the following modes on ventilator is not used for weaning a patient? Fine. The question is, we have discussed this in my video part. Controlled mechanical ventilation, pressure support, SIMV and assisted controlled ventilation. Controlled mechanical ventilation I have discussed in ventilator basics part. This question is a straightforward question. Controlled mechanical ventilation is one thing where I will paralyze all your muscles and whatever the mechanical ventilation is given by the ventilator itself. Right. Pressure support, I have given a classical example. If you remember, if you go back to my videos and see, it is like, if you are like, my professor has said me this story. If the scooter is not starting, if your bike is not starting, what will you do? You will ask your friend to push the scooter, you will put on the gear and you will start. Pressure support is more or less like this. My great professor has taught me, so I will never forget this. SIMV, synchronized intermittent ventilation. This is also a weaning mode. This has been asked many times in your entrance examination. Assisted control, though it is not practiced, assist control can also be used during recovery phase. So, out of which controlled ventilation, that means all his muscles are paralyzed. The word itself is telling you very clearly that controlled, someone is controlling your ventilation. That means, do you use it for weaning? The answer is very clear in front of you. Controlled mechanical ventilation is not the correct answer. So, which of the following modes of ventilator is not used for weaning? It's controlled mechanical ventilation. Right. We'll move to the next question very quickly. A patient with raised ICP posted for neurosurgery. Which of the following agent is preferred for induction? Okay, this is, I don't know the options are right or wrong. If the same options are given, like, A, isoflurane, B, halothane, C, ketamine, D, thiopentone sodium. If the same options are given, I have said you, in my session of inhalational anesthetic agent, in my session of intravenous induction agent, if you combine it and see, inhalational anesthetic agents, they are not preferred for induction in neurosurgeries. Why? I have said it very clearly, inhalation agents, they cause increase in ICP. Here already the patient is having raised ICP. So do you think I use isoflurane and halothane for their induction of anesthesia? No. So I will not use it. So these two options are removed. Again, ketamine and thiopentone, the option will become very straightforward. Ketamine, I said it very clearly, it is not used in neurosurgeries because again it will cause raised ICP. So this is again a pretty straightforward question that have been asked in the central examination. All of the following are signs of successful stellate ganglion block, except. Again, this is a tricky question. This has been asked, I think, in JIPMER. Recently, they have asked in JIPMER. The answer is bradycardia, Horner syndrome, Gutmann sign, nasal congestion. I don't know whether the options are right or wrong. Suppose if the same options are given, I said you, in the interscalene block, there are chances like, stellate ganglion is very close to the brachial plexus. It is present. Stellate ganglion is the lower cervical sympathetic ganglion. If you look at this picture, it is the lower cervical sympathetic ganglion, and sometimes it will get contributions even from the T1 segment also. Right? So it is present near the Chesikh-Neck tubercle. On the C6 or C7 vertebra, there will be a small tubercle. C7 vertebra, there will be a small tubercle. There it lies very close to the brachial plexus. You can see in this picture that very close to the brachial plexus, there is stellate ganglion block. And this lower cervical sympathetic block, this will supply to the sympathetic supply to your face and most of the part of the arm. Right? Now, when I give a stellate ganglion block, classically I said you will get a picture of Horner syndrome. Horner syndrome, what are the features of Horner syndrome? Ptosis, meiosis, anhidrosis, nasal congestion. What is this Gutmann sign? You might have read it in your physiology. Gutmann sign is nasal congestion that is seen after a stellate ganglion block. So all of the following signs of stellate ganglion block are there except Horner syndrome will be there. Nasal congestion will be there. Gutmann sign is more or less the same. I don't know. I am not very sure of the option. But if they have given Gutmann sign separately and nasal congestion separately, yes, I don't know. The question might be wrong. But what is out of all four options, what is the least possible option? The answer is bradycardia. The answer is bradycardia. Why bradycardia? Because, stellate ganglion, this is slightly again controversial. I do accept it, slightly controversial, because if I block right sympathetic ganglion, there might be chances of slight amount of bradycardia. But if I block left sympathetic ganglion, the heart rate will not be affected. The heart rate will not be affected. So, looking at the options, Horner syndrome, Gutman sign, nasal congestion, they are all seen with stellate ganglion block, except bradycardia. There can be chances of bradycardia, but it's not sure, it's not mandatory to have bradycardia. So looking at these 4 options, if the options are wrong, I don't know if there is any other option which I have missed, or if you want to add, just understand the concept so that whatever the question it comes in the future, you can be easily answering it. So out of all the options, bradycardia has got least possible effect. Gutman sign is also seen, that's more or less, it's a nasal congestion that is seen with stellate ganglion. I don't know why they have given this nasal congestion again. So if there is any other option in nasal congestion apart from nasal congestion, you can choose that option. Suppose if the same options are given, let us go for bradycardia. This is a more probable option for it. Right, this is about stellate ganglion. The rest of the question, stellate ganglion, where do we use this stellate ganglion block? It is used in treatment of conditions like complex regional pain syndrome, peripheral vascular diseases. So what does it do? Gutman sign is the stuffiness of the nostrils, which is seen after the successful stellate ganglion block. Okay, the other signs of successful stellate ganglion block are Horner syndrome, engorged veins on the arm, flushing of conjunctiva, sclera, increase in skin temperature, canidosis of the face and the neck. Okay, so the options, I don't know if it is there, bradycardia, you can choose of bradycardia because this is not possible thing. Right, coming to the next question. How to measure the depth of anesthesia? But this question was again asked in NEET 2019, I guess. The answer is very simple. We have discussed it in my videos also. Bispectral index. Bispectral index is very straightforward question. So I didn't keep the option. What are the constituents of EMLA cream? Again, we have discussed it in the video of local anesthetics. EMLA is a eutectic mixture of local anesthetic. It is a mixture of lignocaine and prilocaine. If they have given any other options, choose lignocaine and prilocaine. Suppose if they specifically ask whether it is 2.5% or 5%, I don't know, because I have recently seen 2.5% composition also, and I have also seen 5% composition also. So it's not about the composition. The percentage is either you can have 2.5% lignocaine and 2.5% prilocaine, or 5% lignocaine and 5% prilocaine. I am not very sure what questions they have asked. Suppose if they give both of these options, I'm sure they will not give these 2.5 or 5%, because in market I have a sample also of lignocaine and prilocaine where I have 2.5% sample and also I have a 5% sample. So they will not ask you this kind of question. Suppose if they ask you, choose 2.5% only, because most of the textbook it mentioned it as 2.5, but I have seen 5% composition also. So what is this eutectic mixture? Where do you use this eutectic mixture of local anesthetic? I said you, it is for the surface application. It is a mixture of local anesthetic, lignocaine and prilocaine in equal composition. I apply on the skin with occlusive dressing. Suppose if a child comes to me for vena cannulation, I said you, this is one of the painful thing which I can do on a patient or this is one of my nightmare also, keeping a cannula for a child. It's a very painful process. Children don't cooperate. The veins are not so visible. They start crying. The mother starts crying. All the emotional dramas will come here. I don't want to put it. So what I will do is, most of the corporate hospitals, they have these stickers, labels of Chota Beam, He-Man, etc., something like that. They have on the back side of it, they have this lignocaine and prilocaine. We keep it on the child's arm and we keep it for 45 minutes. This is occlusive dressing. Okay, it is having a mixture of lignocaine and prilocaine. After 45 minutes, I will remove this sticker. What I will do is, I will remove the sticker where I apply some amount of logic. I will not throw the sticker into the dustbin, because the child gets emotionally connected with the sticker. If I throw it, he will cry. So what I will do is, I will keep it on this hand. The child will be looking at this sticker and this area will be completely numb, and I will keep an IV cannula there. So practically, this is what happened in my routine practice. So that's the second part. It has been discussed thoroughly in the video of EMLA cream. Just have a look at it in the chapter of local anesthetics. The fourth question, which anesthetic agent doesn't get metabolized by any organ in the body? I got only two options here. One is thiopentone, the other one is remifentanil. If you look at these two options, I think remifentanil, I don't think like it's a very straightforward question. Remifentanil is the straightforward answer here. Why remifentanil? Because remifentanil is a newer opioid which is metabolized in your body through esterases. through plasma esterases. So what are the other anesthetic agents which are metabolized in your body? The classic example which have been asked many times in your entrance examination is atracurium and cisatracurium. Atracurium and cisatracurium, they also undergo Hoffman elimination. Remifentanil also gets metabolized through plasma esterases. Even mivacurium also gets metabolized. Mivacurium is a neuromuscular blocking agent, shortest acting neuromuscular blocking agent, that is also metabolized through plasma esterases. So 3 or 4 things, and there are pretty straightforward questions except for 1 or 2 questions. The rest of the questions, I feel that these questions are straightforward questions for you to answer. Okay, so having said this, so many things we have discussed in this, so slightly I will add last 15 minutes. What I will try to do is, I'll try to tell you a very simple thing. Preparation strategies. Generally, I am not like, I can't tell you all these motivational, because I don't believe in this. You have to work hard. That's for sure. So I'll not waste much of your time, just to add upon few things. Okay. So after looking at these 10 MCQs which I have collected, what should be the strategy? I said this second part, after this whole discussion of MCQs, if you get the questions, please do post me. I will try to answer it on our Facebook group, or even you can message me or something like that. I'm very happy, because I didn't got the questions properly. I have not discussed that part. Okay, if you remember or recollect, please do post me. Okay, coming to the second part, how to prepare. Okay, just I wanted to add a few points here, how to prepare or how to use these 6 months effectively. Okay, so the thing is, if you look at all these 10 questions, what do you feel? Out of these 10 questions, I am very sure that 8 questions have been discussed by us, or it is given in our marrow. It has been discussed in Q banks. Only 1 or 2 questions where clinical acumen is required, they have been not, because it's not practically possible to tell each and every point in clinical discussion. Whatever I do in my critical care area, it's not practically possible. So my sincere request, those who are preparing seriously for PG examination, those who are doing internship, please make sure that you spend some amount of time in intensive care medicine. Some amount is sufficient. Some amount is definitely sufficient for you for this entrance examination. Again, if you have the basics of the knowledge, that is sufficient, not more than that. Okay, coming to the second part, how to prepare it. So you can blindly believe marrow, and you have seen the result also, right? Many students have got so many good ranks. So you can blindly believe marrow, and you put your heart into it. What is the logo that says? And the dream branch, the dream college, whatever you have in your mind, you can be secured for it. Okay. So some students have asked me a very straightforward question. Sir, I'll tell you that, me last year, one of the repeater, he has asked me this question. Sir, me and my friend, we started preparation together with marrow, the same marrow source we have started, and this might have happened to you also, with the same marrow source, and my friend has got slightly better rank. He is now doing post graduation, and I am sitting in my home struggling with all these 19 books again. Why this has happened? I also followed marrow religiously. What is the difference? Most of the times we have, we feel like, we are rejected, or we feel very low. Please make sure that you are not rejected here. You need to stay focused. So I'll tell you a small story here. I don't know, because I am not very well versed with this motivational thing. I don't know, but recently I read a story. This is not my own story also. I read or I heard it somewhere, which I found slightly motivating. It will not take much time for you. A small 5-minute story. Okay. So the story starts something like that. There are 2 friends. These 2 friends, they start journey from one city to another city. They are moving from one city to another city. It was late in the evening. They wanted to stay at one place, and they wanted to eat the food and spend the night over there. So when these 2 friends, they are sitting at one place, one fellow had got 5 bread pieces. The other fellow has got 3 bread pieces. Okay. They thought like they will share these 5 plus 3 bread pieces, 8 bread pieces. So they will share it equally 4 and 4. Okay. So this was a pretty decent calculation. They were about to begin their dinner. What happened, suddenly the third person came. And he started the moment he came and he said he said, I'm also feeling hungry. Can you share your food? Immediately these people, they got confused. And they said like, brother, we got only 8 bread pieces. We thought we will divide it equally and share. We can't give you more, we can't give you less. So what that third person said is very simple. Logically, he said like, brother, you have got 8 bread pieces. What to do is, we will divide each bread pieces into 3 components. We'll divide into 3 components. So 8 bread pieces into 3, it will make into 24 bread pieces, right? So let us have 8 pieces each. 8 pieces each. So everyone was astonished by his mathematical knowledge, and they divided these bread pieces into 24 parts, and they had eaten that bread and they slept. Next day morning, the third person, he was also about to leave. He said, you people are very good. So what I will do is, I will give you 8 diamonds. 8 diamonds I will give you. You distribute among yourself because you have served me with your food. Okay, he has given 8 diamonds to these friends. Now what happened, the moment they got 8 diamonds in their hands, they are very much happy. So what they have done is, one fellow, like, he said like, brother, let us divide this 8 diamonds into equally. 4 for you, 4 for me. Immediately the person with 5 bread pieces, he said like, how can you divide like this? How can you divide like this? You can't divide like this, because I got 5 bread pieces. I will take 5 diamonds. You got only 3 bread pieces. You take 3 diamonds. Now what happened? The moment they started discussing, they started with an argument and fighting. Everything has happened. And finally they went to a king. The king, and they said, all this happened to us. So please give us justice. The moment the king heard this story, that 5 bread pieces, 5 diamonds, 3 diamonds, 4 diamonds, 4 diamonds, the king gave only one solid judgment. The person with 5 bread pieces take 7 diamonds. The person with 3 bread pieces take 1 diamond. That's it. This is my judgment. Get out. The story ended there. What is this? Completely different angle. So the story ended there. If the story ends there, what is there? We need to apply the logic. Most of you and your friends, you might have started your journey together. You might have used the same strategy, marrow and all these things. But where lies the difference? This story tells the difference. You have seen this, one person has got 5 bread pieces, the other person has got 3 bread pieces. Now if you divide these 5 bread pieces, 5 into 3, 15 bread pieces he has there. The other person has got 3 bread pieces. If you divide it into 3, he has got 9 bread pieces. Out of 15 bread pieces, the person has contributed 7 bread pieces to the third person. Okay, out of 9 bread pieces, 8 bread pieces have been eaten by this person also. So he has given only 1 bread piece. So the king had made the decision of distributing the diamonds 7 to 1 person with 5 bread pieces, 1 to 1 person with 3 bread pieces. This is how the difference comes in your entrance examination. Pretty clear. I found this. I don't know whether you like it or not, but I don't know what to tell. So that's the reason why I said you. So when both of you guys are preparing for this entrance examination, some people able to secure a good rank, some people not able to secure that much amount of rank. Where lies the difference? I have been saying it many times to my students wherever I go and take the class. Whatever you put, whatever the effort you give during your preparation, that makes the difference in your ranks. It's not about, the same app, because, if you look at this same story, you can keep an analogy with us, we all start our journey with the same, more or less, 5 and 3 bread pieces. We all, when we finish off our medical college, we come out with more or less, some person might get 58% of knowledge, some person will get 62% of mark. More or less, we acquire same knowledge. But when it comes to an entrance examination, the whole thing shatters down. The whole thing shatters down. That person might secure 3000 rank. This person might secure 15,000 rank. What is the difference is how much amount of effort you are putting. What is the strategy you are applying. This is the same reason I find, of late very recently, marrow people, we have introduced a concept called as marathon. What is this marathon? A very interesting concept which I liked it very much. Many students have followed it religiously. They have been posting it 5 modules per day. 5 modules per day. The whole reason, and one of our favorite faculty, orthopedics faculty, he has been saying it many times in the videos. I have listened to his videos many times. He said it very clearly. to make you accountable for what you read, because we at the end of the day we feel that we are putting our efforts. Might be your efforts are not reaching to the mark. So the whole reason for keeping marathon is to make you accountable for this session, for this NEET 2021 session. How many modules are doing, and you have seen a pretty good results. Those who have done marathon religiously, they have secured wonderful ranks. So believe in this word, you have to be accountable for these readings. Or how to do this? Only doing modules? Okay, that's one way of doing things. The second thing which I wanted to suggest to you is, how many of you are maintaining logbooks? Logbook? What is this logbook, sir? I have never maintained this logbook. So what is this logbook? I just want you to write it on a piece of paper. Even the same, it has been already told. I want you to write it on a piece of paper, in a book or in a diary, like how many hours you are reading properly. Like, if you get up, suppose, I'll tell you my own story. Today is my second episode of isolation. I'm staying in my room, and this is the 5th day for my isolation. I'm still, if you ask me what you have done in these 5 days, I don't have any answer, because, apart from making this video and some reading stuff, if you ask me how much time I have utilized, I don't know. I don't have much answer. Suppose I am suggesting you are preparing. I am in a different phase, right? So you can't compare myself with yourself, right? So I have some practice, I have been exposed and all this stuff. So for you, when you are preparing, try to maintain a book where you start writing. Suppose if you read from 6 to 8 today morning, right? It's 6 to 8, I read this topic. How much time you have given break? Suppose 8 to 9, you have been looking at your mobile. 9 to 10, you have been watching the movie, watching the TV. Something like that. Leave that time. Write it on a piece of paper. Write it in a book. So that you will, when you go back, when you feel low, you see how many hours you have read. This will make the difference along with marathon. And unfortunately, many students, they thought marathon is only for 1 month. No, marathon is not for 1 month. Marathon is till up to the mark until you reach your destination. So please, if you are not following marathon, please do start marathon. This July 1st on a Doctor's Day, you start this marathon and you continue to do this marathon continuously. Daily 5 modules, minimum of 5 modules, maximum you can do whatever the target you can give. So this is one suggestion which I wanted to do is, don't stop marathon. This helps you accountable and responsible, and write how many hours you are reading, and this will tell you the difference at the end of the session. You will not feel guilty, if you get a less mark, you will not feel guilty. So this is one thing which I wanted to suggest. The second thing which I wanted to suggest to you is, we are halfway through. So by this session, you might be finishing your first reading, and you might be starting or might be in 15 days, coming 15 days or 30 days, you might be starting your first revision module. So the answer is very clear. When you are starting revision modules, the thing is, you need to spend more time on doing more MCQs. You might have planned in such a way, like, first 6 months is for reading. Generally, I am telling, okay, it might be some slight changes are there. So for the first 6 months, it might be reading. The second 3 months is for revision 1. The second 2 months is for revision 2 or revision 3, right? Revisions, they will decide your fate. Alone, if you read, it will not make that much amount of impact. Believe me, you have to revise what you have read. Okay, so if you have not made any strategy of revision, please put some time on your revisions. Not some time, you have to dedicate some amount of time, a decent enough of time for revision, right? So in that revision session, in the first revision session, which I feel is, after reading your first part of reading, in the first revision session, I personally feel you need to spend 60% of your energy in doing MCQs, 40% of energy in gathering the new things, or in understanding the concepts which you have missed in your routine reading in the first revision part. In the second revision part, you have to spend 80% of your energy in doing Q banks. 80% of energy in doing Q banks, only 20% to acquire new knowledge or to understand the concept which you have done the mistake. In the last revision 3, 100%, you need not learn new things over there. So this is what my strategy is. If someone asks me, so if you are planning anything, you plan, I said my plan can't be applied to you because this is my way of reading. If you find it useful, try to apply it. And I have told to many of the students, they have applied it, they have got good results also. So I'm not talking about this, first or second rank. If you are aiming at a decent enough rank, so spend these energies wisely when you are reading. Make yourself accountable. The third thing is, how many of you are concentrating on negative things? Like, when you are answering an MCQ, many students I have asked, they are saying like, when they complete 300 MCQs, they said like, sir, 240 correct, 120 wrong. What is the point in it? So the whole concept of doing MCQs is not only to gain the knowledge for your practice. The second thing is the third, very, very important thing where students forget is accuracy. This examination is aimed at accuracy. You people are forgetting this one because I have asked many students, if you are accurate enough, when you are practicing these MCQs only, you should practice in such a way that you are accurately answering. You have to reduce your negative marking. You have to reduce your negative marking. Please practice it from these coming 6 months. Because many students, last year when this NEET 2020 happened, many students, they called me and they have like, I'll tell you a random example. Suppose one student has answered 300 MCQs, 200 are right and 100 are wrong. The score is 700, right? 200 into 4, 800, 100 minus, that is 700. And one student has answered 260 MCQs and 200 are right, 60 are wrong. Imagine, that is 800 minus 60, 740. So this makes the difference. So please try to maintain the accuracy also when you are doing MCQs. Many students, they forget it. This is one key point which I wanted to tell to you. That doesn't mean that you come down on the numbers. That doesn't mean that you come down on the numbers. You need to maintain certain set of, like, you might have been keeping around 260 to 280 MCQs that you might attempt. So don't come down on the numbers, but try to be very close to the accuracy. This is what I am suggesting for you for your coming entrance examination. To practice it this is not going to happen in a one shot. You have to practicing. And I said when you are spending your energies, initially in the revision 1, you are spending 60% of energies in doing MCQs. When you are doing MCQs, you spend your energy wisely on writing, on accuracy also. The third thing is, whenever you do commit mistake, my again suggestion would be like, you maintain a book. You write like something like, 5 mistakes of my life. The very famous author. No, don't write like that. So you start a book where whatever the wrong you have committed while doing MCQ, whatever it might be, whether it is marathon, whether it is MCQs, grand test, whatever it might be, you have to write down your mistakes in one paper. You have to write down in mistakes, because I always tell to the students that there are 2 kinds of mistakes that student can easily commit. That is, one is a silly mistake. Silly mistake means you have not read the question properly. In this session also I said which of the following is not an initial setting? Not. We are missing that not initial setting, and we are getting mistaken. So this is a silly mistake. Right? So for silly mistake, the answer is very simple, that you need to practice. How to practice? So if you go on doing it, one of the good thing that happens to you when you are doing more number of MCQs is you will know how to eliminate the rest of the options. Okay, and you will reduce on the silly mistakes. The second thing is, some questions we might give it a blind guess. Some questions we are not sure of the concepts. But what will happen, we will just stick it and we will leave it. We will not review it. So my strong suggestion to the students is, please review your MCQs. It's not worthy. Like, I did 300 MCQs, I did 500 MCQs. Unless you read what is there in the explanation, and if you are not reviewing your grand test, what is the point here? And you need to segregate your wrong things into 2 categories. One is silly mistake. The second one is conceptual errors. The conceptual errors, they are suicidal. Unless you conquer on these conceptual errors, either by listening to the videos, either by looking at the Q banks, either looking at the textbooks, whatever. You need to conquer these conceptual errors. Suppose if someone asks you, like, for example, all of the following are included in Jones criteria except. If you don't read that except, it will fall into the category of silly mistake. But you don't know what is Jones criteria. You randomly think it is for rheumatoid arthritis or rheumatic heart disease. Okay, it is rheumatic arthritis, and you kept it something. This is only an example, right? So if you don't know this will fall into that category of conceptual errors. So start writing the conceptual errors. When you are revising, see where you are getting conceptually wrong. So in the first revision only, tackle those conceptual errors. Review the videos, review the notes, review the question banks, whatever, and you try to fix that concepts in a quickly fashion. You will not believe me, the same strategy I applied 10 or 13 years back when I started writing my MCQs, wrong MCQs. In those days, 2007, I wrote my PG. So what happened, when I started writing my MCQs, last 3 months only I did this exercise. I have finished 8 books of my mistakes of my life. Okay, so I was like, I never thought that I will secure a rank in the starting attempt only, like, after finishing of internship in the 3 months period. I never thought that I will get some rank of 300 or something like that. But, this has happened because the day before the examination, what I did was I was looking at these mistakes only. 1 or 2 days prior this examination, I was looking at these mistakes and the conceptual errors. In those times, we didn't have Marrow. The conceptual errors you can discuss with your friends. You can listen to the videos. There are many ways to improve the conceptual knowledge. As I said identifying your weak areas, this is the core thing for your success. If you don't identify your weak areas, many times you dwell upon your only strong areas. And one small simple question in the weak area, everything will be shattered. So please make your schedule in such a way that you concentrate on your weak areas and you improve those weak areas. Right. The fourth thing which I wanted last, I like to conclude it because, it's going to be a very lengthy session for you. I don't want to waste for it. The fourth thing which I wanted to tell to you is after doing all these MCQs, pearls. Pearls are one of the wonderful things which you have in this Marrow app. Why this pearls? Whenever you feel bored, I am like, I don't believe in this word, like, I read 10 hours continuously. Somewhere or other, we get deviated. So at those moments, review the pearls. You make a schedule for the pearls so that this acts as a quick revision tool. So please make a schedule. Whenever you are feeling bored, you don't want to read anything, don't want to do MCQ, you just want to leave this place, you want to go to jungle and stay there. So at that moment, take out your pearls and have a look. Take a break, take appropriate break and have a look at the pearls. When you are looking at the pearls, again, this will add upon your quick memory aspect. Okay, so you will understand where you are going wrong. So these are few of my suggestions from my side, and don't think that there will be something which will be asking beyond Marrow, because I have been seeing this app, working with the app, so many questions. So the Q bank is wonderful, awesome thing. Once you are content, once you are done with videos, please try to utilize the question bank maximally. This is my suggestion for you. So with this session, what I will do is stay healthy, guys. Hope best everything will be good for you. All the best for your preparation. Thank you.